Hello everyone. Welcome back to the series of lectures in hematology. Today we'll be looking at the overall approach to bleeding disorders. Okay, so what is bleeding disorder? So bleeding disorders can be due to defects in the platelets, or it can be due to defect in the coagulation pathway. So it can be a defect due to platelets or defect in the coagulation pathway. So how is platelet disorder different from that of a coagulation problem? So clinically, how will you differentiate that with history and physical exam? So platelet disorders are often acute in nature, right? So if there is a problem with the platelet disorder, in the sense that there is a sudden onset destruction of platelets like in immune thrombocytic purpura, it's often acute in nature. Whereas bleeding disorders usually present at a younger age group, they begin in childhood itself and they are more chronic in nature. Okay. Like for instance, your hemophilia, which is a factor VIII deficiency, you can have a chronic problem. What are the clinical features of platelet disorder? So, it depends upon the severity of the thrombocytopenia. However, most commonly they present with mucosal bleeds, right? They can present with petechiae, which are pinpoint lesions which are present on the skin, or purpura. Right, so they can present with petechiae, purpura, mucosal bleeds, bleeding from the lips, bleeding from the nose, bleeding from the gums, right? So it's not always that there is an immune mediated destruction. In infections also, like dengue fevers, viral hemorrhagic fevers, you can have destruction of platelets and they present like this, right? But when it comes to disorders of the coagulation pathway like hemophilia, more often they are chronic in onset and they usually present with deeper bleeds. Okay, they present with deeper bleeds. And bleeding into the joints, bleeding into the muscles is more common. Okay, so bleeding into the joints, bleeding into the muscles is more common in your bleeding disorders. So, let us look at how will you approach a patient who presents to you with bleeding. Fine. So, first and foremost, you will have to rule out something called as pseudo-thrombocytopenia. Right? So, when does this happen? So, this happens when initially when you do a machine reading, there is a decrease in the count, but if you do a peripheral smear, you will find that the platelets are actually normal. So this happens in conditions like giant platelets. So giant platelets, or if there is physiologically the patient is prone to platelet clumping, then the counts will actually appear to be reduced because the machine tends to read it as platelet. Multiple platelets put together is read as single platelet and hence the counts appear reduced. So that is pseudo-thrombocytopenia. Then you will have to ask for history of fever in this patient. So history of fever in this patient, why is it important? Because if there is an acute drop of platelets, then you have to consider infectious causes like dengue fever, malaria, and other viral hemorrhagic fevers. Also, chronic infections which can predispose to drop in the platelet includes HIV, hepatitis B and hepatitis C. Severe sepsis can also result in thrombocytopenia. Okay, so infectious causes have to be kept in mind, especially when the patient has history of acute fever or fever on and off. Then always think of drugs which can cause thrombocytopenia. Amongst the antibiotics, we have penicillins. Then we have the glycoprotein 2B3A antagonist, which is Apixaban and tirofiban. Okay, so these drugs, especially when they are given in the post-MI period, this can cause thrombocytopenia. Anticonvulsants like phenytoin can cause thrombocytopenia. Then heparin-induced thrombocytopenia is a separate entity altogether. This usually starts 4 to 7 days after the initiation of heparin and chemotherapeutic agents, right? So whenever you see thrombocytopenia, always think of this list of drugs which can also contribute to that. Then what is hypersplenism? So in conditions like a chronic liver disease where there is splenomegaly, or in extrahepatic portal vein obstruction EHPVO where there is larger spleen, or in certain hereditary hemolytic anemias where the spleen is enlarged, in all these places there can be platelet trapping and destruction of the platelets, right? So in these conditions, the overactive spleen can cause destruction of platelets, and this is what we call as hypersplenism. Okay, so the most commonly encountered scenario where the platelets drop because of an enlarged spleen is chronic liver disease. Apart from that, you also have to remember conditions which basically affect the bone marrow, right? So what are those conditions, right? Most of the malignancies like especially the acute malignancy AML, ALL can cause bleeding because of infiltration into the bone marrow, or it can also be because of specific disorders which affect the marrow. For example, an ITP, right? So this is an immune thrombocytic purpura where there can be suppression of platelet production as well. And definitely you have to consider autoimmune destruction. Again, this is a mechanism which is proposed in ITP where we have autoantibodies produced against platelet and there is destruction. We will be discussing about that in detail, right? So this is about the different causes of thrombocytopenia that we should be aware of. Now let us move on to one of the most important disorders and frequently witnessed disorders under platelets, which is your immune thrombocytopenic purpura. So ITP, as the name suggests, is an autoimmune disease where you have an immunologically mediated destruction of the platelets. So this can be classified as a primary ITP and secondary ITP. Primary ITP generally no known cause is found. Secondary ITP usually occurs most commonly secondary to rheumatologic disorders like SLE, rheumatoid arthritis. Then secondary ITP can occur even with viral infections like hepatitis B, hepatitis C and HIV. Okay, so Hep B, Hep C and HIV are some of the secondary causes of immune thrombocytopenic purpura. So prior, this immune thrombocytopenic purpura was also known as idiopathic thrombocytopenic purpura, but the latest term is immune thrombocytopenic purpura. So what are the pathogenetic factors which have been implicated in the ITP? So one is definitely the production of autoantibodies. These antibodies go and cause destruction of the platelets. But apart from that, there has also been some hypothesis that there can be suppression of platelet production as well. So what are the clinical features with which an ITP patient is going to present to us? The ITP patient will present to us depending upon the severity of the platelet count. So they may just present to you with skin bleeds like petechiae or purpura, or they can present to you with mucosal bleeds. Mucosal bleeds includes bleeding from the nose, bleeding from the gums, right? In very severe cases where the platelets are less than 20,000, you can have internal bleeds as well, bleeds in the GI tract, bleeds in the CNS. So these are very severe manifestations of ITP. Okay, but always remember the most common clinical feature with which an ITP patient is going to present is fatigue. So fatigue is basically described as the most common clinical feature with which ITP patients present. Okay, so bleeding into the joints, muscles, etc. is rare. That is more common in disorders of the coagulation pathway. So when you investigate the patient of ITP, what will you find in the CBC? The CBC will just show evidence of thrombocytopenia, right? If there is hemoglobin drop resulting because of an AIHA along with thrombocytopenia, then what is this syndrome called? This is called as Evans syndrome. This is called as Evans syndrome. In the peripheral smear, what are you expecting to find? You are going to find a normocytic, normochromic blood picture along with a decrease in the platelets. Okay. Then in the bone marrow, what will you find? You will find evidence of megakaryocytic precursors. Megakaryocytic precursors will be increased in the bone marrow. Okay. So, do you definitely need a bone marrow for the diagnosis of ITP? The answer is no. ITP is disorder or diagnosis of exclusion. ITP is a diagnosis of exclusion. You have to rule out all the causes of thrombocytopenia that we had mentioned, and then only you can diagnose the ITP. So bone marrow is not a compulsory test that has to be done. There are certain indications for which a bone marrow is definitely required in a patient whom you are suspecting to have ITP. So that includes if the patient has splenomegaly. Okay, so if the patient has a splenomegaly, then this is a definitive indication for a bone marrow examination. If there is an ITP which is basically arising after the age of 60 years. So why is a bone marrow examination required for the diagnosis of ITP? because ITP is predominantly a disorder of the young adult and it's not commonly seen in the elderly adult. So if it's found in the elderly, it's most likely secondary to a malignancy, and that's the reason why we should rule it out by doing a bone marrow biopsy. If the ITP is failing to respond to steroids, right? Steroids are the first line treatment for ITP, and if it's failing to respond, then definitely we have to do a bone marrow. Also remember certain points which are usually odd for an ITP. So what are the odd features if the patient is presenting? You cannot directly diagnose them as ITP. So splenomegaly, presence of splenomegaly is odd for ITP. If there is evidence of pancytopenia, if there is evidence of other cell line involvement, again that you cannot directly diagnose as ITP, you have to rule out other conditions. Then evidence of platelet morphology disturbances, like if there is evidence of any giant platelet, etc., then ITP is going to be less likely. So before you label a patient as ITP, you have to think and consider what are the other options which are probably causing thrombocytopenia in that patient. And very, very important, always remember there are three major indications for bone marrow examination in ITP, which includes the presence of a spleen, age more than 60 years, and failure to respond to steroids. So, how do you classify your immune thrombocytopenic purpura? It's classified as acute, which is usually new onset ITP, persistent when the ITP is present for up to 3 months to 12 months, and we have chronic ITP where the platelets or thrombocytopenia is persistent for more than 12 months. Most of the patients have a persistent or chronic ITP. So, for instance, a patient of ITP presents to you, you have treated them with steroids and some of them can go into remission. Okay, so they may have a second episode of fall in platelets later, maybe if it is triggered by a viral infection and then the platelets fail to recover. But most of the time they have a persistent or chronic disease and they have a relapsing remitting course. Okay, so this is something that you have to remember, that most of the ITP patients have a persistent or chronic course. So what are the treatment options for a patient with ITP? So what is the basic goal of treatment? The goal of treatment is to keep the platelets to more than 30,000. So the safe count at which you will have to monitor the platelet is at goal of more than 30,000, because once the platelet drops to less than 30,000, then the chances of bleeding are very, very high. So if there is an ITP patient on follow-up and his platelets are 80,000, 70,000, then you don't have to worry much. You will have to continue the same line of management. Maybe give them some betel, give them some folic acid, improve their bone marrow functioning. The first line treatment in the management of ITP is systemic steroids, right? It is systemic steroids. If we are giving Visolone, we usually start it at 1 mg per kg per day and you slowly taper it down and then you slowly taper it down. Okay, so you'll have to taper it down maybe over 3 to 4 weeks. And if you're starting with dexamethasone, then you start it at a high dose dexamethasone. It's called high dose dexa, where you give an induction therapy with 40 mg IV OD for 4 days, and then you will have to maybe send them on systemic steroids for a short time and taper it down over 2 to 3 weeks. Now, always remember that you have to rule out secondary causes of ITP before labeling it as a primary ITP. So, most of the time secondary causes of ITP are secondary to immunological diseases, and hence we have to aim at checking an ANA to rule out SLE, rheumatoid factor for rheumatoid arthritis and so on, right? If this ITP is due to a secondary cause, then many times you may have to give steroids for a slightly longer period and then taper it. Okay? So that is your first line management. And how long can you do your first line management? So that depends on the degree of recovery of the thrombocytopenia. If they are having a relapsing remitting course, then in the second time, third time, again you can try a pulse steroid or a high dose steroid and try to taper the steroids a little more slowly. Okay. Alternative first line agents which are used include IV immunoglobulin and anti-D therapy. So what is the mechanism? So these are slightly expensive agents and IVIG more commonly used than anti-D. But the main function is that anti-D is basically the injections which act against your own RBCs. So if this is our RBC, right? So anti-D basically go and coat the RBCs. Okay, they coat the RBCs. Now, when these coated RBCs go to the spleen, now this spleen is having both the platelet and the RBC, right? So, what is the spleen going to prefer? So, if you give anti-D, you are going to have preferential breakdown. You are going to have preferential breakdown of the RBCs more than the platelet, and hence the platelets are left behind and the survival increases. So, this is an indirect way of protecting the platelet consumption. Okay, so the RBCs are going to be preferentially more broken down as compared to the platelet when you give an IVIG or an anti-D therapy. But always remember that there are certain prerequisites for that. Mainly the patient should have a spleen, right? There should be a spleen. In a splenectomy patient, you cannot give this anti-D therapy. And also remember that since you are going to stimulate the destruction of RBCs, there is going to be a consequential anemia that develops, and hence the hemoglobin has to be more than 10 gram per liter before initiation of these therapies. Okay. So, that is about the IVIG and anti-D therapy. What are the second line agents used in the management of ITP? So, we have rituximab, then we have, which is anti-CD20 antibody. Then we have thrombopoietin analogues, which basically stimulate the thrombopoietin, similar to how we use erythropoietin analogues in anemia of chronic disease like in CKD. Here you have thrombopoietin analogues, and what is the name of the thrombopoietin analogues used? So, they are L-Thrombopag and Romiplostim. So, Romiplostim and L-Thrombopag are the thrombopoietin analogues which can be used, especially in secondary ITP, secondary to immunological disorders. Steroid sparing therapies like azathioprine can be used, and the last step in the management is splenectomy. Okay, so you optimize the patient. Patient will have to undergo a splenectomy. The graveyard of the platelets is removed, and hence they will have some remission from the ITP. Okay, so this is about ITP. Now let us move on to the next important topic, which is more in favor of your bleeding disorders, right? So when we speak about bleeding disorders, there are certain important disorders like hemophilia and von Willebrand disease. Today we will be discussing about von Willebrand disease. So von Willebrand disease is the most common bleeding disorder. So this is the disorder of the coagulation pathway, unlike your platelet pathway which we have already discussed. So what is this von Willebrand factor? So von Willebrand factor is a multimeric glycoprotein which is synthesized by the endothelial cells and megakaryocytes. Okay, so von Willebrand factor is a multimeric glycoprotein which is synthesized by the endothelial cells and the megakaryocytes. Okay, so what is the function of this von Willebrand factor? Now the von Willebrand factor is basically a glycoprotein that helps in platelet aggregation, and it helps in platelet adhesion, and it increases the half-life of factor VIII. So this basically is a factor which helps in platelet clumping. So immediately there is a bleeding, you know that there will be formation of a platelet plug, right? So the coagulation cascade is stimulated, and initially there will be fibrin formation followed by a platelet plug. So these platelets have to come together, they will have to adhere to the other, they have to clump together, right? So platelet aggregation and adhesion and increasing the T half-life of factor VIII, all these are the functions of von Willebrand factor. So what are the types of von Willebrand disease? So you have to remember that von Willebrand disease is of 3 types, right? So type 1 and type 3 are quantitative defects. So type 1 and type 3 are quantitative defects. So first let us understand the major differences between type 1 and type 3 von Willebrand disease, and then we will move on to type 2. So which is more common, type 1 or type 3? Up to 75% of the individuals with a von Willebrand disease usually have a type 1 von Willebrand disease. Okay, so type 3 is less common. What is the inheritance? Type 1 is inherited in an autosomal dominant fashion, whereas type 3 is inherited in an autosomal recessive fashion. What is the defect here? In type 1, you have a semi-quantitative defect. Okay, so there is a partial quantitative defect of von Willebrand factor. Here you have a complete loss. There is a complete loss of your von Willebrand factor. So in this type 1, the platelets will be reduced in number, but factor 8 activity is usually normal, whereas in type 3 both will be reduced because there is a complete loss of von Willebrand factor. Okay, so type 1 is usually found in childhood, whereas type 3 occurs much earlier, maybe around 3 years of age itself. Okay, right? So this is about the type 1 and type 3 von Willebrand disease. Remember, both are quantitative disorders. Now type 2 can be classified as 2A, 2B, 2M and 2N, and remember type 2 is qualitative disorder. There is a qualitative, that means that this is a problem with the functioning of the von Willebrand factor. Okay, so remember that type 2A, type 2B, type 2M all are inherited in an autosomal dominant factor, but type 2N is usually inherited in an autosomal recessive fashion. Okay, so what are the defects in 2A? So there is an absence of the high molecular weight portion of the von Willebrand factor in type 2A. Okay, in type 2B there is a gain of function mutation in the A site. A site is basically responsible for platelet trapping. Now if there is a gain of function mutation, this is again a qualitative defect, then there is going to be increased platelet trapping, and because of the increased platelet trapping there will be thrombocytopenia in type 2B von Willebrand disease. Okay, they will have thrombocytopenia, very important. So in type 2A you can see that the high molecular weight multimers are mainly lost, and hence they will present with bleeding, but the platelet count will be normal. Platelet count will be normal, PTA, PTTINR will be normal, but they present with bleed. In type 2B, it is only condition where you can have thrombocytopenia. Type 2M is that there is a loss of function mutation, so there is no platelet adhesion. Because there is no platelet adhesion, and hence the platelet plug formation will be poor, and again they present predominantly with bleeding. In type 2N, there is a loss of function mutation of the D3 component of the von Willebrand factor, which is responsible for the activity of factor 8. Now because of that, you will present with symptoms which is very similar to a defect in the coagulatory pathway, and hence this is also called as pseudohemophilia. So this is also called as pseudohemophilia. Alright, so very clear. Try and remember the most salient features. Type 2B is associated with thrombocytopenia, type 2N is associated with pseudohemophilia. Alright, so fine, this is clear. So this is about the different types of von Willebrand disease. Now, you have to remember that there are certain important acquired causes for von Willebrand disease. So this includes aortic stenosis, myeloproliferative neoplasms and paraproteinemia. So what happens here in aortic stenosis? Because of the stenosis, there is a shear stress that is created, which causes destruction of the von Willebrand factor, and hence they can present with bleeds predominantly. There can be a GI bleed, and GI bleed associated with aortic stenosis is called as Hyde's syndrome. This is called as Hyde's syndrome. Okay, so this is about some of the causes for acquired von Willebrand. Okay, so we have understood that there is a genetic component to von Willebrand and an acquired cause. Now let us understand how do you manage this von Willebrand disease. So definitely the best treatment would be to administration of von Willebrand factors from outside, right? So if you don't have von Willebrand factor, you inject the von Willebrand factor. Apart from that, there is also desmopressin that can be given. Desmopressin or vasopressin is usually given in an inhaled form, and this is going to increase the release. This is going to increase the release of von Willebrand factor, thereby increasing the activity of von Willebrand factor. The only condition where the exogenous administration of desmopressin is contraindication is it is contraindicated in type 2B von Willebrand disease, mainly because it can increase the thrombocytopenia and you do not want that. Okay, So the first line treatment is desmopressin, and definitely you can give 1 Villipran factor concentrates to improve the function. So this brings us to the end of our lecture on platelet disorders. We have learnt about platelet disorder, predominantly ITP, causes of platelet dysfunction, and we have learnt about another very common bleeding disorder, which is von Willebrand disease. Thank you.